about my master's thesis work on measuring the impact on health outcomes of BMET training in Rwanda. So basically, I'll start by going over a little background about what medical equipment situation is like in developing settings, talk about Engineering World Health's BMET training program, give you a little background on health technology assessment, but I'll spend the most of my time talking through methods and results, and there'll be a short discussion at the end. So to give you a little background of the project, we're starting with the premise that training biomedical equipment technicians, or BMETs, to repair and maintain medical equipment actually leads to improvements in patient health outcomes. And secondly, that relationship between health outcomes and capacity building is in fact measurable. To give you a little background on medical equipment in developing settings, so approximately 95% of equipment in public hospitals is actually imported either as donations or as purchases. Now, of that donated equipment, some 96% is actually not functional within 5 years, and I think more significantly, 39% was never functional in the developing setting, which is of course vastly different from what we're used to here. Oh, and the picture you see here is actually a warehouse-sized area of broken hospital equipment at Ruhengeri District Hospital in Musanze, and all of this is waiting to be disposed of. So, given that there is all this non-functional equipment, further research actually found that some 66% of this non-functional equipment is in fact repairable by a skilled technician with locally available resources and very minimal financial investment. So given that background, the Developing Healthcare Technology Lab, run by Professor Malkin here at Duke, actually developed an evidence-based curriculum based on the most common causes of failure of medical equipment. And this has been put into place by Engineering World Health. So this is a little overview of what the training program actually looks like in Rwanda. As you can see, it's a combination of a classroom and on-the-job training. The classroom training is done in 6 8-week sessions, 2 per year for 3 years, and it covers a full range from actual equipment training all the way down to basic anatomy, English, computer skills, etc. And on-the-job training includes both equipment and non-equipment work that they do. So the program itself began in late 2009 in Rwanda, and the initial goal was to train 45 technicians to service every hospital in the country in the first 3 years. So they're just finishing out their first full class. And as I mentioned, there's 2 8-week training sessions per year for 3 years. The program is being expanded to Ghana, Cambodia, and Honduras. In Cambodia and Honduras, it's actually continuing education for already trained technicians. And it's being funded by the GE Foundation. So the healthcare impact of this program has been pretty well demonstrated by people like Chelsea and others in the Developing Healthcare Technology Lab. So for example, what was found is after 1 year, hospitals that had a BMET who had been trained for 1 year actually showed a decrease in out-of-service equipment as compared to hospitals that did not have an EWH-trained BMET. Further, the BMETs actually look at more cases, that is more corrective maintenance cases in a given 12-month period than non-BMET trained. So they're actually looking at more equipment. And finally, they have more communication both in the country and outside of the country when looking for assistance in repairing maintenance. So they're learning a number of skills and they're putting it into play, and so we've seen this, but what isn't clear then is how this is actually impacting patient health outcomes, which is of course the ultimate goal. So the goal of this project then is to look for health indicators where we can actually measure the impact on patient health outcomes. Given that, we started with existing health technology assessment methods. So health technology assessment is a field that examines the health benefits of a given technology intervention. And it's generally been applied in developed settings, and it's generally been very limited to high cost and new interventions. And the reason is it's intended to assist policy making. So they're looking at coverage and clinical guideline decisions. So there's a number of organizations that do this, but as you can see, they're all developed world, and it's a very different scenario that they're looking at compared to what I was what we were interested in the developing world setting. So there's a number of differences. As I mentioned, there's an increase in donated equipment in developing world as opposed to here. Not all equipment is available in all locations, so that you have to keep that in mind. And equipment in the developing world is generally used to capacity, which is not necessarily true here. So given that, how do we actually measure the impact on patient health outcomes? So the objective then of my project was to identify conditions, medical equipment, and health outcomes that can be used as indicators of the impact of the BMET training program on health outcomes in Rwanda. So we start from the premise that providers have a preferred procedure for diagnosis, prevention, or treatment of a given condition. And this preferred procedure requires specific medical equipment. But when that medical equipment is unavailable, they have to fall back to an alternative option. And by going from the preferred option to the alternative, health outcomes are actually affected by this. And that can, of course, cascade down even further. So then to start, I had to focus on some specific health areas, and to come up with an initial list, I first looked at the burden of disease and disability in Rwanda as defined by the World Health Organization, and looked at high equipment areas. So from that, I had at that point an initial list of almost 30 health conditions, pieces of equipment, and outcomes. But many of them we removed from consideration almost immediately. In some cases, equipment just was not critical to diagnosis, treatment, or prevention of these conditions in Rwanda. In other cases, there was a very long time lag between diagnosis and observable changes in health, which would make it very difficult to measure the impacts. In some cases, in the case of imaging, there was actually no easily measurable health outcome. And finally, some conditions just are not widely treated in Rwanda. So, given that we removed many from consideration, ultimately I ended up with a list of 7 areas to consider in the field. The first is neonatal jaundice treatment, either with phototherapy or exchange transfusion, looking at bilirubin level recovery time and infection rate. Next was neonatal thermoregulation, either with an incubator or warmer, looking at infection rate, growth velocity, mortality, and insensible water loss. We looked at 2 areas, 2 acute conditions, airway management and respiratory management. In both cases, we were interested in mortality and hypoxemia. For airway management, we looked at pulse oximeter, laryngoscope, suction machine, and capnograph, while for respiratory management, pulse oximeter, ventilator, and oxygen provision. In the area of HIV/AIDS treatment monitoring, we looked at both CD4 counts using a flow cytometer and viral load counts using a PCR machine to understand how that affected mortality and progression of disease stage. And finally, for surgery, we looked at 2 areas, both equipment sterilization and general anesthesia. For equipment sterilization, we were interested in infection rate, and for general anesthesia, again, mortality and hypoxemia, looking at a number of pieces of equipment. So then from these 7 areas, I developed 3 types of surveys. The first was focused on the director or administrator of the hospitals. So we spoke with them specifically about what facility level health outcomes that we were interested in for each of the focus areas, and also asked them to refer me to specific providers I should speak to in each area. And then I went to those providers and talked to them again about facility level health outcomes, but also about what procedures they prefer to do, what happens when equipment isn't available, what alternative procedures they use, the costs and prices associated with these procedures, and how frequently medical equipment is unavailable and for what reason. And finally, I did a survey of the actual equipment we were interested in, which included speaking with the technicians about their investments, maintenance costs, repair costs, and time. And I actually looked at every piece of equipment that I could, provided it wasn't being used. So then we selected a range of hospitals based on patient capacity, population served, resources that they had, and ended up with 12. That's the map that I traveled the country. So given all of that then, moving on to results. Where did we actually find places where we thought patient health outcomes could be measured, or the impact on patient health outcomes could be measured? So as I mentioned, I visited 12 hospitals. 10 were district hospitals, 1 teaching hospital, and 1 maternal and child hospital. These represented 12 different districts across 4 provinces of Rwanda's 5. I conducted a total of 65 interviews with directors, physicians, nurses, anesthetists, and technicians, and this work was all done in June and July of this year. Pause really quickly and see if there are any questions.
I noticed you have, like, I think malaria was one of the ones that was listed that was not considered.
Yes.
I would think that, like, chemistry analyzers or other equipment might be useful there, but maybe there was some, or is it not treated then? I assume it would be treated, but.
Right, so it is treated, but oftentimes because of the prevalence of malaria, they treat based purely on symptoms. So whether or not the lab equipment works, they'll go ahead and prescribe the medication and treat it.
Okay. So you're saying that a lab equipment just isn't involved that much in the diagnosis process, or?
It can be used, but if it goes down, they pretty much will just presume based on symptoms, and most of the time they're going to be right because malaria prevalence is high enough.
Okay.
So the impact would be there, but difficult to see.
All right.
So I just wanted to bring this up again to show you the 7 areas that we did actually consider. So then based on my actual surveys, I eliminated several of these from further consideration. The first was because, at least in the case of HIV/AIDS monitoring, that is done under a separate administrative path within Rwanda, so it doesn't fall under the purview of the BMETs. Next, in several cases, they were just not used in local practices and procedures in Rwanda. So for example, neonatal jaundice is treated purely with phototherapy. They don't do any exchange transfusion. The capnograph is not used either for airway management or general anesthesia monitoring. And finally, ventilators are not commonly used for respiratory management. In some cases, we just did not find that the equipment was critical to care. So pulse oximeters were not critical to care for acute respiratory management, and both blood pressure and ECG monitoring were not critical for general anesthesia. I want to clarify that that is because the pulse oximeter was available, and the pulse oximeter is more critical. Finally, in some cases, equipment was always available. This was true of most of the equipment for acute airway management, all surgical equipment, sterilization equipment, and some of the monitoring for general anesthesia. Sure.
So obviously electricity is needed for everything. Is that an issue with these hospitals, or do they have a constant supply of electricity?
I didn't discuss. As far as I could see, that was not an issue while I was there. But yes, all of this is contingent, or in many cases this would be contingent upon having electricity, but not always.
So some people are having trouble hearing the questions.
Oh, okay.
Can you repeat the question?
Yes. So that question was, Maddie was asking if I talked to them about electricity, and all of this presumes that electricity was always available. So she was asking about how true that was. And finally, in the case of the infant warmer, we could not identify a clear and measurable health outcome associated with it. And that's because the infant warmer is used for very short periods of time immediately after birth and during specific procedures, but not as a general means of maintaining neonatal temperature. So given all of that, ultimately I was left with 3 areas that were not rejected from consideration, starting from a list of 26. The 3 that were not rejected were using phototherapy for neonatal jaundice treatment, using incubators for neonatal thermoregulation, and oxygen provision for acute respiratory management, be it with cylinders or concentrators. So for each of those 3 areas, I'll give you a little background about the conditions associated with it, my findings as far as what procedures were being done, and what procedure preferences are at the hospitals I visited, and finally, I will project some health outcomes for each of the different procedure options. And so this is because in health technology assessment, generally speaking, the value of an intervention is determined by looking at inputs versus health outcomes. And so in this case, inputs is sort of a vague term because it considers everything that goes into a procedure. So that's personnel time, equipment investments, etc. To serve as a proxy for that, I'm using procedure prices because in Rwanda, procedure prices are set by the Ministry of Health for public hospitals, and it's based purely on these cost inputs. Starting with neonatal, yes?
Do the patients have to pay for what they're getting?
So the question is, do patients have to pay for what they're getting? And generally, yes. Even with insurance, there is a copay. And so they do have to pay for it.
I mean, sometimes I know people just don't have the funds to get the oxygen therapy or whatever.
Right, yes. So yes, again, this would all be contingent upon the patient being able to afford the treatment options. So next slide. So then, starting with neonatal jaundice treatment, newborns have naturally very high levels of bilirubin, which drop down within the first few days of birth to normal levels. But in some cases, bilirubin levels don't drop, and they either remain the same or continue to rise after birth. And if that continues unchecked, it can lead to severe disability or even death. But exposure to light has been found to assist in the breakdown of bilirubin. But the effectiveness of this phototherapy is dependent on a number of factors, including the wavelength of the light, the spectral irradiance, duration of exposure, and exposed body surface area. Onto my findings. So the list you see here on the left are actually the hospitals are 8 of the 12 hospitals I visited where they actually experienced equipment unavailability of phototherapy lamps, generally because equipment was broken down. And the ones you see on the right are ones that they didn't actually ever experience this, but I talked to them about what they would do under those circumstances. And the numbers you see in parentheses are the number of phototherapy lamps each of these actually has. So the diagram I'll show you is slightly complicated, so I'll walk you through it. Each of these boxes represents a procedure option that's actually used in Rwanda. And the letters that are within the box tell you that's the primary preference of that hospital. And I think you can see in one case for Kibalizi, they prefer both phototherapy and sunlight equally. So phototherapy here means conventional phototherapy provided using fluorescent light with either blue or white light bulbs. In some cases, the preferred option is discharge and sunlight. So the patient is discharged and in this case, the patient's family is instructed to sun the baby. And in 2 cases, it's a combination of sunlight and antibiotics. Antibiotics does not actually affect neonatal jaundice, so it's unclear as to why that's being recommended, but that is the case, based on what they told me. So 2 hospitals, when their phototherapy lamps go down, they actually move on to rotating babies, so each infant is placed under the light for 6-hour intervals as opposed to continuously. Ramagana falls back from phototherapy to discharge and sunlight when they don't have enough equipment available, or functioning equipment available, I should say. In 2 cases, multiple infants are placed simultaneously under the same lamp side by side. And finally, in several cases, patients are referred out to a different hospital. I want to clarify that when that happens, it's the responsibility and burden of the patient to seek treatment. So they have to pay for any transportation costs associated with that.
That map that you showed us originally, where the hospitals that you visited, are there more hospitals that are, so like the one up north, well, either there's not, it doesn't look like there's, maybe you didn't visit them, but are there clinics around them, or would they have to travel to Kigali potentially to get treatment? Does that make sense?
Yes. So the question being asked is, looking at this map, what the density of hospital locations is. So it varies quite a bit. So as you can imagine, in the city, there are many, many hospitals. So these are all district hospitals. A lot of times there are health clinics in the area, but often to go to another district hospital, it would be a longer travel. But to give you some, there are about 45 district hospitals total. So that gives you a sense of, Thank you. Moving on to looking at health outcomes themselves. The first one I want to look at is the number of days to recovery of bilirubin level. To walk you through this a little bit, along the x-axis here is the price of treatment. In this case, the price of treatment includes a diagnostic, a consultation with a physician, and phototherapy, if it's used. And along the y-axis is actually the number of days to recovery of bilirubin. So here specifically to project how long it would take to recover to bilirubin level for each of these options, I started assuming an infant who was at least 5 days old and had an initial bilirubin level of 22 milligrams per deciliter. And based on the American Pediatric Association's guidelines, an infant with those conditions would be treated until their bilirubin level fell to 14 milligrams per deciliter. Just to walk you through this, in the first case for phototherapy, given those conditions, based on existing literature, it would take approximately a day for bilirubin levels to recover. In the case of rotation, because the infants are being subjected to a shorter duration, as I mentioned, that impacts the effectiveness of phototherapy, so it would take approximately 2 days. In the case of multiple infants, when you place infants side by side, the spectral irradiance actually decreases, and so because of that, I project it would take about 2 days. And finally, in the case of sunlight and sunlight with antibiotics, again, spectral irradiance is lower than it would be with the phototherapy lamp, so that increases the duration to about 2.5 days. And finally, when patients are referred out, we assume that in many cases they do not actually receive treatment, and so it would be about 4 days to recovery of bilirubin level. So the way to think of, or one way to think of this graph is your ideal situation is where your cost is 0, but your outcome is great. So what's in the top left are really the high value options, and as you move to the bottom right, you go to the lower value options where your cost is very high and your outcomes are very poor. And so these lines are just are efficiency frontiers to give you a sense of, as you move from the top left to the bottom right, you're losing efficiency. And so as you can see, sunlight and phototherapy in this case are the most efficient options. Yeah.
You might have said this at the beginning, but can you give like an approximation of the conversion of money?
Oh, yes. Good question. So it's about 600 Rwandan francs or $1. Yes.
So sunlight would be a preferential option to rotation.
If you are purely interested in the cost and the combination of cost and this one outcome, from the point of view that for the investment you're putting in. Yes, and I was surprised as well.
So the refer out basically means no treatment.
In many cases, the question is refer out equivalent to no treatment, and so I didn't assume that all of it would be no treatment, but in many cases, yes.
Mm-hmm.
And in many cases, bilirubin will actually recover slowly.
Sure. So then it's kind of, seems to me like anyways it's making the assumption that recovery is going to be complete and equal in all these scenarios. It's just a matter of time, how long it's going to take.
Right.
Okay. But I mean, can we assume if they
Right.
don't get treatment, they're going to
Exactly.
recover
So
fully?
in some cases, yes, if you don't receive treatment and your bilirubin doesn't recover, then you can end up with current risk for mortality.
Sure. That seems to me like it'd be, I mean, if I'm a Rwandan parent and you tell me my kid's going to be just fine in 4 days if I don't do anything, that's going to sound pretty good to me, I think. But,
Right.
But I mean, that might not be the exact
Right.
case.
This is on average assuming in some cases they get treatment, in some cases they don't. And then, of
Yeah.
course, the severity will vary, and so there are many assumptions built into
Yeah,
this.
sure. Okay.
So, but yes, that's a fair point. Yes.
Can you talk about why the cost is higher for rotation of multiple infants?
Sure. So the cost for phototherapy, the question was about why the cost for rotation of multiple infants is higher than for just regular phototherapy, and the reason is phototherapy treatment is done, they charge by the day. And so just by increasing the number of days, the cost goes up. Are there any other questions for you? So then what I propose we actually measure then is the difference in the number of days between conventional phototherapy and phototherapy either with rotation or multiple infants, because in the case of sunlight and referring out, the patient would leave the hospital and would be difficult to follow up. The other health outcome we considered for neonatal jaundice treatment is actually fever rate, and the reason is when infants are placed close together and stay in the hospital longer, infection rates go up. And fever can be used as essentially a proxy for infection. So this was slightly unexpected in that the preferred option is actually worse than some of the other options when you're specifically interested in fever. That's because in the case of sunlight with antibiotics, and referring out, the patient is outside of the hospital environment, so they're less likely to become infected. In the case of phototherapy, I looked at existing infection rate information I could find on a pediatric intensive care unit, and that's how I found this number. Oh, I should have clarified. What we're looking at specifically is the monthly fever rate per 1,000 patient days. With rotation, because of the increased time that the infant spends in the hospital, we expect infection rates to go up. And in the case of multiple infants, we expect it to go up even higher because, one, the increased time that they're in the hospital, but two, the proximity to other infants. So again, the outcomes that I recommend measuring would be fever rate for infants who receive conventional phototherapy as compared to those with rotation or multiple infants. Moving on to neonatal thermoregulation. When an infant is born, the expected normal temperature is between 36.5 and 37.5 degrees Celsius. But a neonate's ability to regulate their own temperature is very, very limited. But maintaining thermoneutrality is critical, and thermoneutrality is essentially the temperature range within which an infant's heat loss is minimized and water loss is minimized. And that has been shown to have the best outcomes as far as mortality and disability. So what determines what that range is actually a list of different factors, including gestation period, birth weight, age, initial temperature, and air humidity. Premature infants, low birth weight infants, and very young infants have a much narrower range and are less capable of maintaining thermoneutrality. So it's particularly critical for those infants. Thermoregulation is particularly critical for those infants. Moving on to my findings, as you can see, 11 of the 12 hospitals I spoke with actually faced shortages of incubators because of not having enough functioning equipment. Again, the numbers in parentheses are the number of incubators they actually have. The only one that didn't was the teaching hospital in Kigali. So for premature low birth infants, the preferred option for every hospital was using an incubator. When the incubator was unavailable, most of them went to placing multiple infants in the same incubator. In a couple of cases, the second alternative option was kangaroo care. And that's for those of you who aren't familiar, the infant is placed naked on the mother's chest to maximize skin-to-skin contact. In some cases, they use an infant warmer, which is a radiant heat source from above, as opposed to the incubator. And in one case, their alternative option is a heat lamp, which is essentially placing the child next to a heat lamp. And finally, if even that fails, in one case, they would refer the patient out. I want to say one thing about kangaroo care. The specific population that we were looking at here is very low birth weight infants who are very young, very premature. And so for that particular population, all of the physicians I spoke with preferred incubators to kangaroo care, even though kangaroo care is very popular for other categories of patients.
Before you go on,
yes.
Back up, I don't think I've seen those numbers before. That's a lot of incubators at Mohima.
It's a mother and child hospital.
And Rwanda also?
Rwanda is one of the bigger hospitals that's actually being turned into a provincial hospital. It's the one in Wisconsin that has the big equipment.
The picture.
Yes.
You might have. But with the survey, or the interview, I guess, how did you give them options, or was it open-ended?
That's a good question. So the question is if I gave them options or it was open-ended as far as their preferred and alternative procedures. So I would first ask the question of what do you do, and if they didn't answer right away, I would say, do you use the incubator? Do you put multiple infants? I would walk them through some options, but other was always an option. Do you do anything else?
So when they gave the response that they referred people out, is
Mhm.
that, did you lead them into that, or did they?
That was one of the options I gave them. And it was, did you do this? The question was about if referring out was one of the options I provided or was one they provided. So the first health outcome I looked at for neonatal thermoregulation was insensible water loss rate. This is important if you're considering dehydration. So specifically, as I mentioned, we're looking at extremely low birth weight, very premature, and in this case, hypothermic infants to project these outcomes. So the reason insensible water loss rate is much lower for infants in an incubator versus the other options is because in an incubator you have humidity control and you can maintain a very high humidity. You cannot do that with the warmer heat lamp or kangaroo care. And so we see a much higher insensible water loss rate. And in the case of referring out, again, as previously, we assume that in many cases this is the equivalent of no treatment. And so the measurements I would propose to do then are between incubators and the other options. Unfortunately, insensible water loss rate is actually quite difficult to measure in practice. You need to have very careful measurements of fluid intake and fluid output. So for practical reasons, I actually am not recommending this. The next health outcome I looked at is monthly infection rate. And as before, because infants in the hospital have a much higher infection rate than outside the hospital because of the hospital environment. In the case of placing multiple infants in an incubator, because of proximity to other infants, we would expect the infection rate to go up. As with insensible water loss rate, unfortunately for this population, infection is difficult to measure. This is because you can't use fever as a proxy for it. You would actually have to do a different test, and depending on the infection, that could be a lab test or an X-ray or something else. So because of the practical difficulty, again, I'm not recommending this measurement be done. Moving on to 1-month mortality risk. In the case of the incubator, it's at about 25% for this extremely ill population, unfortunately. For multiple infants, placing multiple infants in the incubator, I expect mortality rates to go up, and that's because when a single infant is in the incubator, you can set the incubator temperature using a skin probe that's on that infant. When you place multiple infants, you can just set the temperature of the incubator. And as I mentioned previously, the range of temperatures that are ideal for an infant is very narrow. So when you have multiple infants, you have to do the best you can for 2 or 3 or 4.
Did you get an idea about what your population would be if you actually measured this? Like how many babies are born less than 28 weeks and survive a month?
I guess
This would be a really small population.
right. So when I was projecting these health outcomes, this is a relatively extreme case. I imagine you would still see a difference with a population that's not quite this sick. But as I go forward, yes, that is something I'll have to take into consideration.
28 weeks
is tiny. And, yeah, very rare. Continuing with mortality risk, in the case of the infant warmer and the heat lamp and kangaroo crib, the combination of not having temperature control and not having the humidity control, we would expect to see higher mortality rates. I just want to clarify that in referring, if a patient, as Chelsea mentioned, this is a very tiny, very sick baby, referring out would increase mortality significantly. And so this chart then ended up being somewhat skewed because of how far away refer out is from the other options. So this is still about a 15% difference, which is quite high. Yes.
So the cost of kangaroo care is so high because the woman stays in the hospital, so you're factored in the hospital stay.
Yes.
So theoretically, she could do kangaroo care at home, but you don't have a way to measure that outcome.
Right. So the way that the question is about the cost associated with kangaroo care, and if that includes hospitalization. And it does, and that's actually how it's done in Rwanda. Is they actually have kangaroo care beds in the hospital, and the mother and child both stay in the hospital.
Maybe I missed this, but how are those mortality risk percentages estimated, or where did those numbers come from?
Right. So I basically went back into the literature and found what I could. In the case of mortality, there were 2 papers looking at incubator use from the 1960s. I think they were in England. They might have been here.
Okay.
And so I used those as approximates for Rwanda because
Okay.
that's relatively comparable.
Okay. But there was some study for this particular condition, birth weight, gestation time?
It was not exactly these, but it was essentially this. It was between, I think the 2 papers I looked at were between 800 and 1600 grams
Okay.
and things like that. So
Okay.
comparable, but not necessarily
Okay.
exactly the same. So these are estimates, not.
Yeah, because like with multiple infants, I mean, would that have been studied, or?
No, so the way I came up with what it would look like for multiple infants is there was a study that compared infants who were placed in incubators with humidity control versus, with servo-controlled temperature using the skin probe versus
right.
not.
Right.
And those are the papers from the 60s.
Okay.
And that's where I got that risk difference,
Sure.
or risk ratio, I think.
I wonder if there might also be like an increased infection risk of having multiple kids in the same incubator. Or I don't know how you would parse
Yes.
that out, but.
I assume there would be, yes.
Yeah.
And then that in turn could affect
Right.
mortality, yes. This is not a particularly complex projection, but yes, there are probably a number of factors here that would
Sure.
lead to the increase in mortality.
Sure.
Yeah.
Sorry. The efficiency claims, so as you move out, it becomes more efficient, right?
Right. So the first question about the efficiency frontier. So here is the least efficient, there is the most efficient. So as you go.
Okay, but to continue, but that's efficiency defined purely on the price, right? Because that would mean that referring out would be more price efficient than.
Right. It's a combination of price and the health outcome. So even though the health outcome is really poor for referring out, because the price is so low,
It becomes a preferential option to all the rest.
if you're interested in maximizing specifically for this particular outcome and cost, yes. Yeah. Hopefully that's not what they're doing. The final outcome I looked at for thermoregulation was growth velocity, essentially how quickly the baby is gaining weight. Again, for the incubator, the incubator is the best option, and again, it's the combination of both temperature control and humidity control that gives you that. And as you lose those with placing multiple infants or using either the heat warmer or the lamp, etc., you expect growth velocity to decrease. Moving on to acute respiratory management. Specifically, the patient population I looked at here was hypoxemic patients, and hypoxemia is a condition in which the oxygen level in the blood is low. In this case, hypoxemia specifically, I defined it as, or it is defined rather as, an oxygen blood saturation below 91%. Generally speaking, you'd actually do this with arterial blood gas, but because that's difficult to measure, I chose instead to look at oxygen blood saturation, but there's a clear relationship between the two. So this is this is treated with a combination of supplemental oxygen and mechanical ventilation. And treatment continues until the patient is able to maintain an oxygen saturation level of at least 95% without outside assistance in room air. So only 9 of the hospitals I visited actually had trauma wards, and of those, 4 experienced equipment not being available, while 5 told me what they would do in that situation. Again, the first preference for everyone was using either an oxygen cylinder or concentrator. In 2 cases, when this is not available, they switch to prioritizing patients. And in this case, what that means is the patient that has the highest likelihood of surviving is given treatment first. Once that patient is stabilized, then they will move on to the next patient. In 3 cases, they only use ventilation using the bag valve mask. And finally, in 1 case, they will refer to a different service within the hospital that had different equipment provision. So the first outcome I considered for this was 24-hour mortality risk. I want to clarify for acute respiratory management in general, looking at oxygen provision, there is very, very little literature done in this area, and most of it is very recent. So the oldest paper I found was from 2008, so it's not very well studied. Given that, though, I think we can all agree that if a patient has low oxygen levels, providing supplemental oxygen would lead to better outcomes. Not providing supplemental oxygen would lead to worse outcomes. Specifically looking at 24-hour mortality risk, the best case would be with using either the cylinder or concentrator, when we expect mortality to increase pretty significantly when you prioritize patients, in that essentially one patient is left untreated. And in the case of bag valve mask, you're just providing mechanical ventilation, no additional oxygen. So once again, mortality would be quite high.
No, I want you to finish up. You just said a few more slides.
Okay. And the other health outcome we considered was 1 hour oxygen saturation level. So essentially after 1 hour, the status of the patient. And this is important because the longer a patient remains hypoxemic, the more likely they are to develop brain injury, disability, or death. So we assume that for patients that receive oxygen therapy, either through the cylinder or concentrator, their oxygen saturation level is brought up to about 98%. In the case where you prioritize patients, essentially one patient's oxygen saturation level would improve, once wouldn't, so on average would be about 94%. And finally, in the case of bag valve mask, where no additional oxygen is being provided, it's just mechanical ventilation, oxygen saturation would remain quite low. So then, from all of that, essentially we come down to 3 studies to consider. One is, again, neonatal jaundice treatment using phototherapy lamps, looking at fever or days to recovery of bilirubin level. One is looking at neonatal thermoregulation using the incubator for looking specifically at mortality risk and growth velocity, which you just need a scale for. And finally, oxygen provision for acute respiratory management, both 24-hour hospitals and 1 hour oxygen saturation. I'm actually going to be here for the next 3 months focusing this down further. I would not recommend doing all of this, obviously. So focusing it down to 1 or 2 key health outcomes and specific. Yes.
Adriana? Can you just hang on for a second for doing that? It's a little hard to hear. Some of us are pretty poor of hearing like me.
Great. So over the next 3 months, I'll dive much deeper into the literature and try to pinpoint what the best indicators are to select from this list. What's Chelsea's? So in conclusion, I believe that a link exists between patient health outcomes and medical equipment repair and maintenance, and that this is in fact measurable. And over the course of the next few months, hopefully we'll develop a study that will actually measure this impact on patient health outcomes. That's it.
Thank you. So why don't we take 5 or 10 minutes for questions, and then we got one question from England, if you don't mind me starting, which says, great presentation. Have you critically examined the assumptions, interfering factors for each treatment? Doctor presence or motivation, good user training, drug supply problems, these will be noise in your data.
That's an excellent point. And as I said, I will spend the next few months developing these.
Say the question again.
Oh, I'm sorry. Yes. So the question was, have I considered all of the other factors that affect these patient health outcomes, including drugs, providers, everything? And that's an excellent question, and those will all be things that we need to consider carefully while we're designing the studies. As of now, no, I have not started down that path. That will be high on my list of things to look at.
I'm still kind of hung up on this days to recovery thing on the
Okay.
on the bilirubin. So, is there going to be more research into that in terms of like, because it seems like you're starting from the assumption that all the kids are going to turn out fine in the end. So then, what's the point of the bilirubin therapy? You know, so
Sure.
You know, if you have a kid who's got too high bilirubin and we don't treat them, some of them are going to have complications.
Yes.
And you know, how many and how serious are the complications? Is that something you're going to
That's part of what I'll be doing as this next step, is going farther, as far as I can in the literature, to try to see what exactly those numbers look like and to see how feasible, and it might end up being that this is not something that's worth further studying. But I don't have those numbers, so it's what I'll be doing.
And that's something that you'll be trying to find through the literature?
As much as possible.
Yeah, I gotcha. Okay.
I don't quite understand your points. Why would the fact that they would drop into another treatment category with whatever complication affect this question?
Well, I guess we're trying to figure out, health outcomes of the treatment, which in this case is a Billy light. So if the Billy light's broken or if it's working, there's going to be a difference in the treatment the patient receives. This seems to be operating, to me at least as I understand this chart, is saying we're looking at the recovery in terms of number of days. So no matter what treatment you receive out of any of the 6 options here, in 4 days or less, the kid's going to be totally fine. So
I should clarify that the longer your bilirubin level remains high, the more likely you are to have those complications.
Sure.
And so there's a health value to recovering quickly.
Right.
And again, that 4 is an estimate. That's in some cases some won't recover.
But I can imagine some could be much worse than a full recovery in 4 days.
Yes.
And that would be interesting to explore.
Right.
So this is an important question because, as she said, we're now trying to formulate the next study.
Okay.
So we're trying to make sure that these health outcomes really have mileage. I assume mortality, you would have asked the same question.
I think that's a very valuable thing to look for.
Okay.
Sure.
So the issue is, if you can release the patient sooner from the ward, in this case it's ICU or NICU, what I'm hearing you say is that's not a very compelling
Right, like we're saying recovery time in number of days. Well, what if some don't recover? How are they factored into this? You know, if some patients recover in 2 days and others recover in 6 and others die, I mean, where does this person who died fit into this averaging number of days of recovery? Are they just not in that calculation, or where's the kid who died? I mean, in calculating the number of days to recovery, it seems to me like mortality or I don't know how you would go about quantifying it, but some sort of measurement of the seriousness of your long-term health implications due to complications would be a valuable and interesting thing to look into.
Like a tally.
Yeah, something like that. I don't know how it would be quantified exactly, but yeah.
No, I think that's a great point. That's something I'll hopefully be figuring out.
Some more questions? How about from the back there? You guys are all quiet. How about from Cambodia? I texted him, but he was texting back.
No questions.
I have a question about the antibiotics and the fever. So it seems counterintuitive to give antibiotics just for jaundice, but if you're looking at fever as your outcome, then antibiotics will presumably help with fever.
Yes.
So how do you parse out the fact that they're actually getting treatment for infection while getting the wrong treatment for the jaundice?
Right. No, that's a great question. And so
I'm sorry, what was the great question?
So she was asking. Brilliant.
Yeah, that was enough. That was a great question. You're done.
So her question was, if antibiotics are being provided for jaundice, even though it doesn't affect jaundice, it does in fact affect infection rate. So this would in fact affect using this outcome of fever. And yes, so we would have to, of course, take into account how antibiotics are used. If it's only being used in the case of certain patients who are being discharged, we wouldn't be following up with them anyway, because sunlight therapy is done outside of the hospital. So they would fall outside of our subjects. But if patients who are being treated in the hospital are also being provided with antibiotics, then yes, we'd have to see that.
Another question by email is, the analysis you're proposing measures the effective equipment. It's supposed to measure the effective equipment maintenance and repair. Actually, it's supposed to measure the effective training people to maintain or repair equipment. But equipment availability is a confounding factor.
Yes.
So how are you going to separate out repair maintenance, which obviously training does impact, versus availability, which could be budget and all kinds of other things.
Right. And so part of that is, when I was doing the equipment survey and I was talking about how many phototherapy lamps do you have, one of the questions we ask is, essentially, is this equipment breaking down and are you repairing and maintaining it? So obviously, in some cases, that's in fact why we rejected certain pieces of equipment, is because they really just were not breaking in, they were not being repaired, and therefore it would not impact this question. But yes, functioning equipment versus availability of equipment will be something, again, that will need to be taken into consideration. So we'd have to look for cases where the BMET is actually repairing the equipment. Or maintaining.
So did you ask the users if they had enough available to them?
No, I didn't specifically ask them if they had enough available, but when I asked them why they were using the alternative procedures, sometimes the answer was, I don't have, the equipment is working. Sometimes the answer is, we just don't have enough.
Any more questions?
So everyone just want the food.
All right, thank you very much, Mary.